I'll move on to introduce COPD as a topic, and then eventually move on to pulmonary rehabilitation. So the definition of COPD, as we all know, it's a chronic, it's a common, preventable, and treatable disease that's characterized with persistent respiratory symptoms and airflow limitation that is due to airway or alveolar abnormalities, and it's usually caused by significant exposure to noxious particles or gases. So that brief definition is the definition of COPD. And the etiology, I know this is very small, but it's an interplay between known risk factors like smoking and genetic factors, like some people who maybe have abnormalities in development of lungs or alpha-1 antitrypsin deficiency, or generally abnormalities in the airways, and also exposures that come on along the way. Like we know many infections, tuberculosis. No one has studied okay, we know that in Africa, childhood malnutrition, early pneumonias, all these things are eventual predictors of COPD in adulthood. And the other one, of course, is I'll show from this graph. This is a graph from the gold slides, but a paper in the New England Journal of Medicine, where the trajectory of COPD is changing from the classic pathway, which you see as trajectory 1, which involves the classic decline in lung function as you reach 60 years or 70 years, coming downwards. So the other trajectory is, you can see the yellow one, trajectory 2, where people don't develop normal lungs, okay? The lung development doesn't reach what would be optimal for the required capacity of an adult, and those people may not have an accelerated decline, but may just have the same rate of decline, but because their peak was not very high, was not optimal, they end up getting COPD as a result of genetic predisposition or factors that affected in a suboptimal development of their lungs. Like from the pediatric side, like asthmatics may be at risk of that pathway because of altered biology in the early stages. So the others, of course, any acceleration may be any new event like an infection or risk factors like smoking. So I think this is known already, and what we can take from this slide is, one, we know that COPD is progressive and it's not going to cure when it comes in, but our objective when it comes in is to halt progression, slow down the recurrence of symptoms, and prevent exacerbations which make the person symptomatically worse after every episode. So a meta-analysis by Holbert and colleagues found about 384 million people living with COPD globally. This was around 2010 and 2006, sorry. And studies were between 1990 and 2000. There's another meta-analysis still from this one by Holbert, which was around 2010, which still showed a large global burden. And the disease is higher in people who are more than 40 years, but this changes. Yeah, there was another meta-analysis which found 384 million. So the global prevalence is about 11%, and you can see the confidence intervals and increasing prevalence in developing countries because of risk factors like biomass and smoking and the like. So from the global perspective, we've had our landmark study in COPD in this country, and you can see the prevalence was 16.2. The study was done in Masindi, and interesting enough, there was a high prevalence of COPD in the category between 30 to 39 years, which is very dangerous in terms of a precedent, and higher in women, as we saw. Here, the major risk factors were really biomass, among others. As the chair mentioned, I also looked at COPD patients in the Mulago Joint AIDS program, and these were people infected with HIV. This is an abstract, but the main risk predictors of COPD in this population was TB, shortness of breath as reported by most patients, as well as a low BMI. So the predictors differ depending on the population that you're looking at, and that's something that we can pay attention to. So why are we looking at this topic today? For those of you who have lived with patients with COPD or patients with chronic lung diseases, these patients do not have peace, I should say, because their symptoms are recurrent. You wake up every day, you're ready to go to work. He has to cough and cough and cough. Then you have to buy needless antibiotics. You have to have limitation of activity with symptoms that are affecting you. So COPD carries a large contribution to the disability, adjusted life years and burden, as well as high costs, especially in our setting where antibiotics are over the counter. These symptoms really lead to a lot of money being spent needlessly in COPD, either poor symptom control or even when exacerbations come in. So the economic burden of COPD, even away from exacerbations, but natural symptomatology, from making you suboptimal in terms of your exercise and capacity to carry out different activities, the overall money spent on symptoms is quite high. And this is where we really want to highlight the role of non-pharmacological management of COPD, which includes pulmonary rehabilitation, which is our topic today. So these are factors which affect disease progression, but I'm sure you are aware of most of these: genetic factors, gender, and continuous exposure to noxious particles. And these are some of the topics which are involved in pulmonary rehabilitation. When you hear pulmonary rehabilitation, it actually has a component of patient education. And very many times, pulmonary rehabilitation is thought of as chest physiotherapy, which is actually a much broader term than chest physiotherapy. So I really don't think I should spend time here, but maybe what I should mention is the cardinal symptoms of COPD, which is cough, recurrent cough, shortness of breath, and sputum production. And given the presence of risk factors, we know that our diagnostic tool of importance is spirometry. And from this chart, you can see that these are volume time curves from a spirometer. And I think what I can say is these are respiratory ratios of the forced expiratory volume in one's. The normal person should exhale more than 80% of their air in the first second when you use a forceful exhalation. But in proportion to your total vital capacity, if FEV1 over FVC is less than 0.7, we subject you to a bronchodilator, which if you maintain a less than 0.7 figure, it shows that you have obstruction or delayed emptying of your lungs, leading to retained air in your chest. So again, these are known. This is the gold classification of COPD, and it's based on the categories of the FEV1. More than 80% predicted is gold 1. Gold 2 is 50 to 80%. Gold 3 is is 30 to less than 50, and less than 30% of the predicted FEV1 is very severe disease. So when you diagnose patients with COPD, as evidence is really showing that you might give several treatments based on the classification of the severity in terms of gold grading, but they are not necessarily always linked to the symptomatology of patients. So you must also get the symptom score of patients. And these are some of the tools that are available for use, like the COPD assessment tool, which is used in the, which is very highlighted in the GOLD guidelines, or the chronic respiratory questionnaire, or the St. George respiratory questionnaire, the MRC dyspnea score, because these can tell you about the daily impact of COPD on someone's life. So this is also in the revision of the Goal 2019, they have tried to emphasize these symptom score tools versus adjusting management based on these versus trying to tie this to, like in the previous, you would add that grade to the functional score. But now you can use the functional score alone to decide treatment. And this is an example of the COPD assessment tool, and it's a spectrum of severity depending on where the patient feels that they belong in terms of the spectrum in much of these activities of daily living. And so I'm going through this sometimes because I know many of you here have seen it before. And this is the modified dyspnea scale for the MRC. And again, it's a progressive spectrum of severity of dyspnea or difficult in breathing based on the symptomatology of patients and how they perceive their functionality. So these are some of the assessments that you do when people are in pulmonary rehabilitation programs that can help you know whether you're assisting a patient in terms of their functionality. Okay, so I'll skip this and go to the next. So in this slide, you can see that this is the refined ABCD assessment tool. And on the horizontal axis, you have the modified medical cancer research score, the MRC dyspnea score. And along the vertical line, you have the number of exacerbations. Okay? So, as well as the CAT questionnaire. So, if for instance I have one exacerbation and my CAT score is less than 10, or my MRC dyspnea scale is less than 10, I am class A. So I might be gold stage 3, but then my symptoms are class A. However, if I have many exacerbations, let's say 2 exacerbations or more, or 1 exacerbation at least leading to an admission, even when my CAT scores are least, then I will be grade C. So these are important classifications when it comes to trying to manage patients. As you can see, the different pharmacological approaches that group A, you only need bronchodilator. But then all these other groups, you need combined medicines like a long-acting beta agonist plus an inhalational corticosteroids, as well as for group C, the long-acting muscarinic agents like tiotropium. So this is the pharmacological management of COPD, which is not the focus of our presentation today. But now, again, from the GOLD guidelines, these are the non-pharmacological strategies of COPD management, which try to prevent exacerbations and optimize symptom control in these patients. So you can see that really pulmonary rehabilitation programs are very pertinent in management of these patients. And this is the focus of our presentation today. To underscore this, the summary of the guidelines trying to show the non-pharmacological management of COPD. These are the patient groups that we have been talking about, which is patient group A, B up to D from the other symptom control grading. But other than group A, which is more or less asymptomatic, almost all the other groups, pulmonary rehabilitation comes really as a major management strategy of COPD. And if you recall from the chair, this is not something we are doing really as programs or as COPD managing doctors or people. So now we reach trying to understand what is pulmonary rehabilitation. And maybe this is a field of long definitions. Again, from the American Thoracic Society and European Respiratory Society statement of 2013, there was an amendment of the definition of 2006 of COPD, and now pulmonary rehabilitation is defined as a comprehensive intervention based on thorough patient assessment, followed by tailored patient therapies that include but are not limited to exercise training, education, and behavior change, okay? And designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote long-term adherence to health-enhancing behaviors. So from this definition, we see three major components, among others. And this is exercise training, education, as well as behavior change. And these are all designed to improve the functionality and mental state of people living with chronic respiratory disease. So who are the implementers of pulmonary rehabilitation? Virtually all people who are involved really in terms of close management, but very much you can see the physicians and all these other health workers, including physiotherapists, respiratory therapists, nurses, psychologists, behavioral specialists, nutritionists, social workers. Everyone has a role to play in pulmonary rehabilitation, okay? And one other outstanding thing is that interventions are based on the unique needs. Remember, this is after thorough patient assessment, and then you tailor the intervention to the needs of the patient. So the goals of pulmonary rehabilitation are to minimize symptom burden, maximize exercise performance, promote patient autonomy in terms of decisions surrounding their management, enhance their activities like activities of daily living, and improve their quality of life, and with long-term enhancing, health-enhancing behavior change, as we'll see along the way. So what are the components of pulmonary rehabilitation? I will highlight the major components, which is exercise training, behavior change, and patient education. So exercise training. What do we mean when we talk about exercise training? Now, in COPD, the capacity of exercise is largely limited by shortness of breath, and this is one of the main contributors of exercise incapacitation. But the dyspnea in COPD is multifactorial. It can involve muscle weaknesses or what we call peripheral muscle dysfunction, and this is largely inadequacy of muscle strength from supply of nutrients generally, and eventually deconditioning progresses from that sequelae. Then we have what we call dynamic hyperinflation, and the way to understand this is every time you blow out your air when you're exhaling, after exhalation, then you inhale, and more or less like with your tidal volume, when you blow out what is required to be blown out on exhalation. Then you inhale and to fill that gap, and our tidal volume is about 500. Now in COPD, people have incomplete emptying, and with the incomplete emptying, because of the obstruction, inhalation comes in and finds a partially full lung from what would be expected from a healthy person. So that progressive accumulation of lung volume is what is called dynamic hyperinflation, and it's different from the static hyperinflation, which is generally reduced stretch or recoil of the lungs. That also affects ventilation. Now, dyspnea is also brought in by increased respiratory load, and this is a combination of several factors, some arising from poor ventilation, others from poor gaseous exchange, and eventually increased work of breathing, which again contributes to worsening of the shortness of breath. Then the defective gas exchange, many times these people have like dead space, like physiological dead space, more or less pathological, like an emphysema patient. The alveoli are so big they can't contract. They're usually alveoli are tethered together. They contract as a unit, expand as a unit in inspiration and exhalation. But with such COPD patients, if you're like emphysematous, that because of progressive destruction of alveolar walls, they become sacs, which are unable to contract and expand. So you always trap in air, which is not replenishing itself with gas, which vital gas like oxygen. So eventually you have dead space and defective gas exchange, in addition to endothelial issues. And then you have the natural decline of lung function, which is age-related. As you know, many of our patients are old, as well as physical deconditioning as a result of age. So, as you can see that the capacity, one thing that we want to highlight from this slide is from literature, you actually see that for capacity which is necessary for training intensity and duration to allow modification of skeletal muscles is maintained even in severe COPD. So severe COPD does not take away the capacity of muscles to kind of improve in function. That capacity for necessary training intensity and endurance and duration to allow skeletal muscle adapt is maintained even in severe forms of COPD. But you have to navigate around to tap into this capacity, because eventually it's the one which will help you improve your lung function. And this is now, if you improve skeletal muscle function, then you improve ventilatory capacity. And we'll understand more what this actually entails. But you can sit down here that gains in skeletal muscle function lead to gains in exercise capacity. But you may not be able to detect this maybe with a spirometer, but the functionality of a patient, and these are the intricate nuances that come in pulmonary rehabilitation, that I may still maintain the same gold category, but my exercise capacity might improve because of increased strength of skeletal muscles. And this increased strength of skeletal muscles also is associated with improved oxidative capacity. Remember, poor oxidation also worsens muscle function. It is also associated with improved efficiency of muscle function and eventual reduced ventilatory requirements. So again, exercise training, if you have borrowed from depressed people, it improves mood, improves cardiovascular function. The shortness of breath in COPD is largely multifactorial, and many COPD patients also have comorbidities which involve cardiovascular disease. So this underscores the importance of cardiorespiratory assessment of a patient before you take them through a full physical activity, because pulmonary rehabilitation takes about 8 to 12 weeks. So you may need to understand, like sometimes you can use stress ECGs or treadmills to see how much someone can endure to try and, to screen for cardiorespiratory dysfunction, because again, this can be a limitation. Then it also, if you do like stressing, it can help you evaluate needs for supplemental oxygen, because these are also associated with benefits of, if you give like supplemental oxygen to a person who is exercising muscles, you may eliminate the equation of shortness of breath. Now, my fatigue in physical function may be because of shortness of breath and physical muscles. But if you give me supplemental oxygen during the activity, you might eliminate shortness of breath's impact. Then you allow me to tap into exercising muscles, whose improved function will feed back by improved ventilatory capacity and eventual reduction in what? In shortness of breath. So this is what, these are things you can do before exercise training to try and rule out things that may cause problems to optimal exercise functionality. Okay, what is the physiology of exercise limitation? Ventilation, as you know, ventilation is the work of respiratory muscles. This is breathing out and breathing in. This is ventilation. And it involves the several inspiratory muscles as well as the expiratory muscles. So in COPD, ventilation requirements are high because there is always increased work of breathing. Remember, obstruction leads to more increased work of breathing. So that's why you always have high increased respiratory effort. You have a dead space which you have to overcome. You have deconditioning of muscles. you have outflow obstruction, and you have dynamic inflation. So all these combine themselves and offer a ventilatory obstruction to function. So these combined factors can increase your ventilatory requirements. So you can see here that whereas they all, if they all combine, they increase your inspiratory requirements and increase your sense of dyspnea, because then they lead to worsening ventilatory effort. Now, away from ventilatory effort, you have the gas exchange limitations, and we have already mentioned that many COPD patients have hypoxia, and exercise triggers more hypoxia. So as you exercise, you become more hypoxic. The carotid bodies sense your levels of carbon monoxide. They trigger increased ventilation. Then you have lactic acid accumulation. Then this is also going to lead to muscle fatigue. So you're now not only getting hyperventilation with increasing your work of breathing, you're also getting lactic acid buildup, which is wearing out your muscles. So again, this is going to cause you to tire out early. So these gas, and if you break down lactic acid, again you build more carbon dioxide, which may trigger more increased ventilatory effort. So again, so this is some way where you can see that sometimes supplemental oxygen may do what? May reduce the production of lactic acid and allow more endurance during physical activity in exercise training, to allow you to prolong pulmonary rehabilitation endurance. And it also has these other advantages of carotid body inhibition because of low CO2 levels. So you might, at the start, sometimes for some patients who have very severe disease, you may need to assess a need for supplemental oxygen such that you can allow patients to endure, and over time as they improve, maybe they can have less demands. So that's another component. From ventilatory, we now have gas exchange limitation. And now you have the cardiac limitation, and here we have the role of pulmonary hypertension, which eventually leads to, which this can be the result of hypoxia causing vasoconstriction or narrowing in the pulmonary vessels, remodeling because of vascular injury. This COPD has inflammatory changes, and increased resistance because hypoxia again is going to lead to build up more generation of red cell mass. All these can lead to impaired flow through the pulmonary vasculature. So the eventual pulmonary hypertension in the severe forms, of course, goes to copulmonary, but before that you have like functional impairments, because if the right ventricle becomes big, then the septum shifts towards the left. In exercise, you need a highly functional left ventricle. So trying to have an left ventricle which can keep up with the rate of demand during physical activity will be impacted if your right ventricle has hypertrophied. So this is again important to, this is an important contributor of exercise limitation. So then you have lower limb muscle dysfunction. Now this is a combination of factors: shortness of breath, then you have peripheral muscle deconditioning, you have muscles which are not well nourished, oxidative damage, reactive oxygen species. So corticosteroid use, as they are common, and they are associated myopathies. So eventually you have people who report fatigue is one of the most reported symptoms, especially in cycle-based activity like either repetitive exercises. They cause the muscles to develop, these factors cause development of contractile fatigue, which eventually leads patients to tire out very quickly. So again, here it's important to note that COPD patients tend to have a higher lactic acid production than other normal healthy controls, which, as we have seen in earlier slides, increases their ventilatory requirements and increases the work of breathing that muscles have to overcome. And COPD patients also have an increased tendency of carbon dioxide retention, which leads to lactic acidemia. So these combined factors lead to early exercise termination because of still worsening functionality of respiratory muscles. So here I highlight that improving skeletal muscle function is a pertinent goal for exercise training because it eventually improves ventilatory effort in pulmonary rehabilitation. Now there is a whole document about the skeletal muscle abnormalities in chronic respiratory disease which can be looked up in literature. Sorry, I have allergies. So now you have, again, further limitations of exercise are caused by limitations of respiratory muscles. There are several respiratory muscles, the intercostal, like for inspiration, you have intercostal muscles, sternocleidomastoid, latissimus dorsi. All these muscles around the chest are really involved very much in inspiration, including the major muscle, which is the diaphragm. Now, one thing to note is diaphragms in COPD patients kind of try to adapt to the increased work of the chronic overload and eventually develop greater capacity to function. But their adaptability in terms of increasing their effort is overcome by the dynamic and static hyperinflation that we have talked about, which kind of changes if the chest is now changes the natural shape of the chest where the diaphragm can easily contract downwards. This chest is already maybe increased in anterior-posterior diameter, rounded already, so the capacity of the diaphragm's adaptation in strength to overcome this structural kind of function which eventually result into structure because of increased air trapping, abnormalities of the lung, place the diaphragm at a mechanical disadvantage to overcome the functional limitations, even when it tries to adapt. So it's then eventually you still have a buildup of carbon dioxide, more dyspnea, desaturation, and reduced exercise performance. So from these different factors, you can see that when a patient comes in with COPD, the quickest temptation, if I have an exacerbation, is to give me a bronchoagonist and think that all will be what? All will be well with my function. But from what we have seen, this is not true. And looking deeper into this topic, I also try to understand the limitations these patients have in terms of functionality. It is not laziness or one problem that is causing exercise limitation. It's a whole spectrum of issues that are affecting what? Exercise in these patients. And these are some of the important take-home messages from this topic. So principles of training, just to tap into a bit what happens in pulmonary rehabilitation. Remember, exercise training is one major component. Principles involve the trained muscles for endurance. Then you have interval training. Some people are so functionally incapacitated they can't do progressive activity. But what I saw from the literature is assessment for COPD specifically, and not other things like maybe cardiac disease or what, but for COPD generally, there's not much difference, or in fact there's no significant difference. If someone can do continuous activity, or if someone can pulse the activity and say, I can do 30 minutes rest, do 30 minutes, it's more or less can yield the same optimal outcomes. They also do resistance or strength testing and muscles to improve that. They train upper limbs, they train lower limbs. So in pulmonary rehabilitation, as you have seen from the holistic approach to ventilation, it's not only flexibility training is the one which doesn't have so much known advantages, and this involves different posturings of the chest or thorax to try and improve ventilation, which would have thought would have the highest yield, but it's a combination of the other muscle trainings that lead to benefits. Now, one principle that we should not forget is to maximize benefits. Like I said, if I am chronic bronchitis, then my chronic vasoconstriction causes shortness of breath. Give me a long-acting beta agonist before the exercise. That kind of widens my airways and allows me to eliminate or reduce that problem to now tap into the next problem of muscle muscle weakness to allow more endurance. So it is important to know how to optimize. And again, if as exercise goes on, these patients keep building up, and because now inspiration, expiration is coming in quickly because of exercise. So your breathing pressures are quite high. So sometimes you may need this non-invasive ventilatory support. You arm it to the patient to try and overcome the positive pressures to allow more inspiratory ease, but to allow continued endurance of the exercise. So that is something about exercise, and I don't know how much time I have yet, but okay, so 10 minutes. Okay. So briefly, the second component is behavior change and collaborative self-management. Now, what are the things that we talk about? Now, away from the underlying pathology, many of the functional impairments in COPD may also come along with perception. They may impair quality of life, and people may adapt differently to the same pathology. But my symptoms may be more perceived because of maybe how I perceive the disease, or I am dying, and all this. So behavior change tries to optimize the patient's understanding of the disease and to help them adapt to the symptoms that they have. And here the strategies are aimed at early recognition of signs of maybe signs of an exacerbation, early intervention, and also trying to help them overcome the functional limitations. Let me give you examples of this. This behavioral change includes, among many things, cognitive behavioral therapy. Now, under this, there is something called operant conditioning. And here the principle, the theory is recurrence of a behavior depends on its consequences. For instance, if you tell me that this breathing technique during exercise may work for you, if I do it and I yield more meters in the 6-minute walking distance, then that reinforces, and the patient has some motivation to carry on that activity again. So that operant conditioning can help, is what you're trying to tap into. And the emphasis here is not to bring a super formula, but to try and help the patient figure out what things work for them in different scenarios to improve their function. This is part of the CBT of pulmonary rehabilitation. Then changing cognition this is mainly about beliefs, ideas, about, the consideration that beliefs, ideas are strong determinants of emotion and behavior. For instance, and these may change over time depending on patient experiences. So an example here, a patient may not use a drug if over time their cognition gives them that this drug is not useful. So even if you think, you explain and what, but the patient has their bias. You've seen this. Like the standard treatment of malaria here is Coartem. You reach someone's like, me Coartem doesn't work on me. Me paracetamol, that's weak for me, but these are based on evidence. So this kind of apparent, this cognitive behavior patterns are the ones which the behavior change in pulmonary rehabilitation tries to tap into. And here, if a patient, let's say, as we know that these patients have chronic shortness of breath, but if every time the patient, let's say, walks on that, maybe walks from place A to place B to try and exercise, shortness of breath comes in, and the mind triggers to, I am dying, I am suffocating. That will kind of tell them, slow down, don't try that, keep in your small pocket of not exercising. Then that leads to them never trying to do exercise, and eventually that's the downward spiral of ventilatory function. So this is what cognitive behavioral therapy tries to do, and it has components of self-efficacy. This is the principle of a patient contributing positively and to their health, overall health, and knowing that this and this and this work for me, this and this and this don't work for me. And they evolve all these strategies that health workers can use either experiences from peer patients that at first I was doing this badly. Maybe if you run like this, or if you feel like this, try a bronchodilator if you try it. So these are like peer groups in pulmonary rehabilitation setups. And also trying to really understand this mastery experience is something like reinforcing and trying to undermine failure. If I try strategies and they lead me to feeling bad, don't castigate me, try and help me try other strategies. So eventually you have to do what we call collaborative management. You agree on a management plan with the patient, then you write down goals and you keep revising them over time. So the other component is education away from behavior, and this is mainly an ongoing process, educational topics concerning nutrition, understanding of their disease, function of the respiratory system, different aspects, smoking cessation and benefits. So you need to make sure patients understand the disease such that they can participate in their management and prevent downward spiral of poor quality of life. Then the other one is to also initiate topics regarding advanced care planning. For instance, in one study in this reference I was looking at, like 30% of COPD patients who died like 1 month before their death, they did not know. They thought maybe they would die in 2 years or 1 year. So they can't know if, how do I plan these symptoms? Okay? If I'm having shortness of breath, does it mean I'm dying? What's the natural history of my disease? And any other advanced orders that they may want. But trying to initiate some conversations of the progression of the disease might help patients understand better. So from all these, then it looks like pulmonary rehabilitation may be perceived as rigorous. What is the optimal timing? So most times people have had pulmonary rehabilitation in only the severe forms of COPD, thinking that's where there is benefit. Now, from newer data, benefits of pulmonary rehabilitation cut across almost all stages of COPD. Because one is the observation that the correlation between airflow limitation and symptoms like dyspnea, overall health status, exercise performance is not strong enough to say that if you're gold stage 2, this is your shortness, this is your weakness. These other symptoms may be there even in gold stage 1, gold stage 2, and not necessarily only stage 3 or stage 4 disease. But if you don't work on them, then again you progress quite quicker versus someone who has them. So the thing is, even after an exacerbation, you can introduce pulmonary rehabilitation shortly after discharge, during discharge, or after discharge. It is safe even after an exacerbation. Okay, so what things are involved in pulmonary rehabilitation? So there are many tools that can be used to assess patient-centered outcomes. And here you can use the symptom score like the MRC dyspnea score, fatigue assessment, which can assess intensity or impact of the intervention, depression scores, functionality tools like Kanofsky. Then there are multiple symptom assessment tools like the CAT tool, St. George Respiratory Questionnaire, the Clinical COPD Questionnaire, which has been used around here as well, and exercise performance tools. Now, exercise performance tools may involve like the field walking tests. An example of this is the 6-minute walking distance, and this is done like, you can even do it on that walkway, you can do it in a pitch, you can do it anywhere. You have to just put point A and point B, then keep marking like, the distance is 30 meters, and you can keep marking maybe every 5 or 10. So the patient, you start your timer and you're like, okay, start walking. Then the patient starts walking, and when they reach the end, they go around. So they keep walking, and over 6 minutes, you just keep encouraging them a bit, and you're like, how much distance can they cover at their self-pace over 30 minutes? And this is why he was saying that it's not expensive to do pulmonary rehabilitation. You can also do the incremental shuttle walk test, and this is one which requires a shorter distance, like 10 meters, from like point A up to the end of the wall. And the patient here follows the timer. It rings, boop, then I begin walking, then I reach the other end. then I wait, so it then sounds again. So it keeps calculating for you how much time you need to walk from point A to point B. So as the time goes, it increases, begins ringing, poop, then you walk. Before you reach the other side, it's saying poop, poop, then you're like, hey, I need to work harder. So as you achieve, it keeps increasing the frequency of your, how much you need to walk from point A to point B. And it's interesting that with this timer now, you work against the timer. You stop when the patient is progressively failing to reach like by a half a meter. And I found that these are all easy to really modify into what can be done. So this is a picture of the 6-minute walking test, a graduated corridor, which can be done from anything. This is a picture adopted from a presentation by Dr. Katajira from a previous pulmonary rehabilitation program. As you remember, the physiotherapy department, where it used to be. And this is the walking across for that 6-minute walking distance. So this can be adopted, and the work from that exercise is what you see in this study. And at least we have 2 of the authors in here. And one thing that you can see is it was feasible, clinically important improvements were seen in quality of life. Maybe the important thing from these exercise performance tools is what is called the minimal clinically important difference. And this is the gain that is associated with substantial improvement in the lung function. And it is set for various, like the 6-minute walking test, it is, for most studies, they have quoted around 54 meters improvement, maybe after pulmonary rehabilitation, being associated with benefit. And here you can see the incremental shuttle walking test was 299. This is what they had at baseline, and then after the rehabilitation, this is what they have. So these are the different improvements that you find in pulmonary rehabilitation. Now, looking at other non-COPD diseases, this is a summary a bit of the different studies which have looked at the role of pulmonary rehabilitation in other chronic lung diseases, and the general message is in many of them it has benefit. So this is my second last slide. There have been efforts regarding pulmonary rehabilitation. The first one was a 2006 statement by the ATS and ARS. The second one is, which really talks about comprehensively advances in pulmonary rehabilitation, is that 2013 statement of pulmonary rehabilitation, which was very much the source of the work I've talked about today, because it's a summary of different meta-analyses and different studies in this topic. And why I highlighted the 2015 statement, and these are the things that pulmonary rehabilitation. So the statement says, enhancing implementation, use, and delivery of pulmonary rehabilitation. And the rationale is pulmonary rehabilitation has demonstrated physiological, symptom-reducing, psychosocial, and health economic benefits for patients with chronic respiratory diseases, but it remains underutilized. The objective for this statement of 2015 is to enhance implementation, use, and delivery of pulmonary rehabilitation in management of suitable patients worldwide. As you know, much of these diseases will not show up, but all these disadvantages will be significantly reduced by pulmonary rehabilitation. So what do we have for the future? We have what's under construction is the Kupumwa House for Heart Lung Rehabilitation, the Lung Institute, and my personal wish, this is something I've thought about because of the ease with pulmonary rehabilitation programs. You know, there are many sophistications that come around mentality and mindset. For instance, like in pediatrics, you have the Blantyre Coma Scale for what? For children. It says eye-opening, directed, followed, not following. appropriate response to what? To a cry. But it's a sophisticated word, blantyre in Malawi, you know. Then you, well, what's the other one of encephalopathy? West having criteria for scoring encephalopathy. It says no subtle changes, small changes in mood, grade 1, grade 2. Then it becomes, you know, a widely and recognized Glasgow-Coma scale. So with this, I think we can adopt something that can be called the Kampala model of pulmonary rehabilitation and just try and look at literature and what things we can involve in a package of pulmonary rehabilitation. And this is something that can be done almost in all district hospitals in the country. They all have compounds, people hang their clothes there, people do what. So I think, for me, I really think this is something we just need to get a standardized from these different physical testing things that we've said, and so this is maybe what we have as a Kampala model, and maybe try to like expand it globally, and people will adopt it because there is no really known modality for our low middle income countries for pulmonary rehabilitation. And the other thing is, I think over time there will need to be emphasis on introduction of pulmonary rehabilitation in training programs. These can be recommendations to training departments like the College of Health Sciences, Department of Medicine, surgery where they have thoracic patients, sports people, and then of course pursuit of funding to roll these things out even when it's not too much, but very much increased awareness, which we are doing today in regard of a day of lung science. With that, I really end my talk today. Thank you.